Hello class, this is Emergency Care and Transportation of the Sick and Injured, Chapter 26, Soft Tissue Injuries. And in this chapter we're going to learn to deal with all types of soft tissue injuries, from burns through severe lacerations, through severe types of abrasions, and how to care for each. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. There are different types of trauma. The first we're going to talk about is soft tissue trauma and the recognition and management of soft tissue trauma. You have wounds, burns, electrical types of injuries or wounds, chemical wounds, thermal wounds, and chemicals that have become exposed by the eye and are also present on the skin. We're also going to discuss the pathophysiology, assessment, and management of wounds, avulsions, bite wounds, lacerations, puncture wounds, and incisions. We're also going to discuss burns and electrical injuries, chemical types of burns, thermal burns, radiation burns, and also what is known as crush syndrome. Now, to introduce soft tissue injuries, the first thing I want to point out is that soft tissue injuries are common. They can be as simple as a cut or a scrape, but they can also be as serious as a life-threatening internal injury. Do not become distracted by dramatic open wounds. Do not make the critical mistake of neglecting other life-threatening conditions such as airway obstruction. So they may have severe trauma where perhaps a portion of their intestines has become exposed. But while that's dramatic and certainly life-threatening, a non-patent airway is much more critical, because if you have no airway, the rest is moot. So make sure you keep your focus on the most dramatic things at hand in terms of ABCs, and then we take the rest from there, and we're going to discuss all of that. The soft tissues of the body can be injured through a variety of mechanisms. A blunt injury occurs when the energy exchange between the patient and an object is more than the tissues can tolerate. You can have a penetrating injury, which occurs when an object breaks through the skin and enters the body. Barotrauma, which is commonly seen in blast injury victims, refers to injuries that result from sudden or extreme changes in air pressure. Burns may also result in soft tissue injuries. Soft tissue trauma is a common form of injury. Open wounds account for approximately 4.1 million emergency department visits in 2011 alone. Wound care is one of the most frequently performed procedures in emergency departments or EDs across the United States, and most of these injuries require basic interventions such as wound irrigation, dressing, bandaging, and limited suturing. Death is often related to hemorrhage or infection. Uncontrolled hemorrhage can lead to shock and, of course, death. When the skin barrier is breached, invading pathogens can cause local or systemic infection. Infection can be life or limb-threatening, especially in children, older adults, and people with diabetes or other conditions that may compromise the immune system. Effective strategies to reduce injury and death from burns include smoke alarms, controlling the temperature of hot water heaters, and enforcing building codes that regulate electrical and construction practices. Now let's discuss the anatomy and physiology of the skin. The skin is the body's first line of defense against external forces and infection, and it is the largest organ in the body. It is relatively tough, but it is still susceptible to injury. Injuries range from simple bruises and abrasions to serious lacerations and amputations, and injuries may expose blood vessels, nerves, and bone. In all instances, the EMT must be able to control bleeding and prevent further contamination to decrease the risk of infection and protect the wounds from further damage. Apply dressings and bandages to various parts of the patient's body. Skin varies in thickness depending on the person's age and in the location of the skin itself on the body. Skin is thinner in the very young and the very old, and skin is thinner on the eyelids, lips, and ears than on the scalp, back, and soles of the feet. Thin skin is more easily damaged than thick skin. Now let's talk about anatomy. The skin has two principal layers, the epidermis and the dermis. The epidermis is the tough external layer that forms a watertight covering for the body. The epidermis is composed of several layers. The dermis is the inner layer of the skin, and it contains the hair follicles, sweat glands, and sebaceous glands. Blood vessels in the dermis provide the skin with nutrients and oxygen. The illustration on this slide shows that structure of the skin. So you see the epidermis there on the very top layer, and then the dermis underneath that contains the hair follicles and sebaceous glands and so forth. Make sure that you're very familiar with this particular slide. It is extremely important not only for testing purposes, but for you to be able to recognize the extent and depth of an injury to a patient. Skin covers all the external surfaces of the body. The various openings in the body are lined with mucous membranes. Mucous membranes provide a protective barrier against bacterial infection and invasion. They secrete a watery substance that lubricates the openings. They are moist, whereas skin is generally dry. Some more about physiology. Skin serves many functions. It keeps pathogens out, it keeps fluids in, helps to regulate body temperature. The nerves in the skin report to the brain on the environment and many sensations. The nerve pathway connection allows the body to adapt to the environment through responses in the skin and surrounding tissues. Any break in the skin may allow bacteria to enter and increases the possibility of infection, fluid loss, and loss of temperature control. Any one of these conditions can cause serious illness and even death. There are three types of soft tissue injuries. The first type is a closed injury. This is damage that occurs beneath the skin or mucous membrane. The surface of the skin or mucous membrane remains intact. And then you have open injuries, where there's a break in the surface of the skin or mucous membrane. It exposes deeper tissues to contamination. The third type is burns, and this damage results from thermal heat, frictional heat, toxic chemicals, electricity, or nuclear radiation. Now let's discuss the pathophysiology of closed and open injuries. The pathophysiology includes healing of wounds, which is a natural process that involves several overlapping stages, all directed toward the larger goal of maintaining homeostasis or balance. Cessation of bleeding is the primary concern. Loss of blood hinders the provision of vital nutrients and oxygen to the affected area, and it also impairs the tissue's ability to eliminate wastes. The end result is abnormal or absent function, which interferes with homeostasis. The next wound healing stage is inflammation. This is where additional cells move into the damaged area to begin repair. White blood cells migrate to the area to combat pathogens that have been invaded into the exposed tissue, and lymphocytes destroy bacteria and other pathogens. Mast cells release histamines, and inflammation ultimately leads to removal of foreign material, damaged cellular parts, invading microorganisms. To replace the area damaged in a soft tissue injury, a new layer of cells must be moved into this region. Cells quickly multiply and redevelop across the edges of the wound, and except in cases of clean incisions, the appearance of the restructured area seldom returns to the pre-injury state. Despite the changed appearance, the function of the area may be restored to normal or near normal. New blood vessels form as the body attempts to bring oxygen and nutrients to the injured tissue area. New capillaries bud from intact capillaries that are adjacent to the damaged skin. These vessels provide a channel for oxygen and nutrients and serve as a pathway for waste removal. In the last stage of wound healing, collagen provides stability to the damaged tissue and joins wound borders, thereby closing the open tissue. Collagen is a tough, fibrous protein found in scar tissue, hair, bones, and connective tissue. Collagen cannot restore the damaged tissue to its original strength. Now let's discuss closed injuries. Closed soft tissue injuries are characterized by a history of blunt trauma, pain at the site of the injury, swelling beneath the skin, and discoloration. A contusion or a bruise is an injury that causes bleeding beneath the skin but does not break the skin. Contusions result from blunt forces striking the body. The epidermis remains intact, but cells within the dermis are damaged and small blood vessels are usually torn. The buildup of blood produces a characteristic blue or black discoloration called ecchymosis. A hematoma is blood that is collected within damaged tissue or in a body cavity. It occurs whenever a large blood vessel is damaged and bleeds rapidly. It is usually associated with extensive tissue damage. A crushing injury occurs when a significant force is applied to the body. The extent of the damage depends on how much force is applied, the amount of time that the force is applied. Continued compression of soft tissues will cut off circulation and produce further tissue destruction. When an area of the body is trapped for longer than 4 hours and arterial blood flow is compromised, crush syndrome can develop. When a patient's tissues are crushed beyond repair, muscle cells die and release harmful substances into the surrounding tissues. Harmful substances are released into the body's circulation after the limb is freed and blood flow is returned. Advanced life support or ALS providers should administer IV fluid before the crushing object is lifted off of the body. Freeing the body part from entrapment also creates the potential for cardiac arrest and renal failure. Consider requesting ALS assistance for situations of prolonged entrapment prior to extrication. Compartment syndrome develops when edema and swelling result in increased pressure within a closed soft tissue compartment. Pressure increases within the compartment, which interferes with circulation. Delivery of nutrients and oxygen is impaired, and byproducts of normal metabolism begin to accumulate in those tissues. There is pain, especially on passive movement. The longer this situation persists, the greater the chance for tissue death. EMTs must continually reassess skin color, temperature, and pulses distal to the injury site if the crush injury is suspected. Severe closed injuries can damage internal organs. The greater the amount of energy absorbed from the blunt force, the greater the risk of injury to deeper structures. You must assess all patients with closed injuries for more serious hidden injuries. Now let's discuss open injuries. Open injuries differ from closed injuries in that the protective layer of the skin is damaged. It can produce excessive bleeding. A break in the protective layer or mucous membrane means that the wound is contaminated and may become infected. Contamination is the presence of infections or infectious organisms or foreign bodies such as dirt, gravel, or metal in the wound. Address both excessive bleeding and contamination in your treatment of open soft tissue wounds. The 4 types of open soft tissue wounds are abrasions, lacerations, avulsions, and penetrating wounds. An abrasion is a wound of the superficial layer of the skin caused by friction when a body part rubs or scrapes across a rough or hard surface. An abrasion usually does not penetrate completely through the dermis, but blood may ooze from the injured capillaries in the dermis. Some examples are road rash, road burn, a strawberry, or rug burn. Anybody that's ever ridden a bike as a child has certainly had one of these. Abrasions can be extremely painful because the nerve endings located in this area are now exposed. A laceration is a jagged cut caused by a sharp object or blunt force that tears the tissue. An incision is a sharp, smooth cut, and the depth of the injury can vary. Lacerations and incisions may appear linear, regular, or stellate, which is irregular. Lacerations or incisions that involve arteries or large veins may result in severe bleeding. An avulsion separates various layers of soft tissue, usually between the subcutaneous layer and the fascia, so that they become either completely detached or hang as a flap. Often there is significant bleeding. Never remove an avulsion skin flap, regardless of its size. An amputation is an injury in which part of the body is completely severed. You can easily control bleeding from some amputations, such as the fingers, with direct pressure and pressure dressings. If there is massive bleeding, you should stop the bleeding, which often requires a tourniquet, and treat the patient for hypovolemic shock, and make sure that you're familiar with tourniquet procedures and policies in your area. A penetrating wound is an injury resulting from a piercing object such as a knife, ice pick, splinter, or bullet, for example. These objects can damage structures deep within the body and cause unseen bleeding and damage. If the wound is to the chest or abdomen, the injury can cause rapid and fatal bleeding. Impaled objects are objects that penetrate the skin but remain in place. The concerns with this type of injury are damage to structures deep inside the body, presence of foreign materials inside the tissue that can lead to infection. Stabbings and shooting often result in multiple penetrating injuries. Assess the patient carefully to identify all wounds. Count the number of penetrating injuries, especially with gunshot wounds. Leave the distinction between entrance and exit to the physician. In a shooting, determine the type of gun when possible, but do not let this delay patient transport. If you can't identify it, you can't identify it. Sometimes patients or bystanders can tell you how many rounds were fired, but given the stress of the environment, their information may be unreliable. You may have to testify in court in this type of situation, so make sure you carefully document the circumstances surrounding the gunshot injury, the patient's condition, and the treatment that you give. Blast injuries often result in multiple penetrating injuries. The mechanism of injury from a blast injury is generally due to 3 factors. The primary blast injury is damage caused by the blast wave itself and the sudden pressure changes of the explosion. The secondary blast injury is damage that results from flying debris that causes multiple penetrating wounds. And the third is tertiary blast injury, where the victim is thrown by the explosion, perhaps into another object. Now let's discuss patient assessment of closed and open injuries. It is more difficult to assess a closed injury than to assess an open injury. Anytime you observe bruising, swelling, or deformity, or if the patient is reporting pain, the possibility of a closed injury should be considered. An open injury is easier to assess because you can see that injury. Of course, let's talk about scene size up. And the very first thing, as we have said every lecture up till now and will continue to say, is scene safety. Observe the scene for hazards to your crew, bystanders, and the patient. Scene safety is always first. Then assure that the scene is safe and consider the need for additional resources. Take the necessary standard precautions before approaching the scene. A minimum of gloves and eye protection. Open soft tissue injuries can be messy, but should not take priority over more serious life-threatening injuries, such as an impaired airway, for example. Be careful where you put your hands, place your equipment, and how you package the patient for transport. Focus on controlling the bleeding. Now let's talk about the mechanism of injury, or MOI. Look for indicators of the MOI as you assess the scene. They can help you develop an early index of suspicion for underlying injuries. Interactions with the patient and your assessment will provide you with additional information about the extent of the injuries. The MOI may provide information about potential safety threats. Use all available information to evaluate scene safety and consider whether additional resources may be necessary. With primary assessment, you want to focus on identifying and managing life-threatening concerns and identifying transport priority. Form a general impression. Important indicators will alert you to the seriousness of the patient's condition. For example, is the patient awake and interacting with his or her surroundings, or is the patient lying still, making no sounds? Is the patient responding to you appropriately or inappropriately? Is the patient's breathing pattern rapid, slow, deep, or shallow? What is the color and condition of the patient's skin? Does the patient have any apparent life threats? Closed soft tissue injuries may appear to be minor, but could indicate serious internal injuries. Do not be distracted from looking for more serious hidden injuries, and make sure you check for responsiveness. If the patient is alert, ask about the chief complaint. Administer high-flow oxygen via a non-rebreathing mask to a patient whose level of consciousness is less than alert. Treat for potential shock and provide immediate transport. If the patient has significant trauma, perform a rapid exam, look for life threats, and treat them as you find them. If the patient has obvious life-threatening external bleeding, control the bleeding first, even before airway and breathing, and then assess and treat the ABCs and provide treatment for shock. Now let's discuss airway and breathing. Providing high-flow oxygen may help reduce the effects of shock and assist in perfusion of damaged tissues, particularly in crush injuries. Ensure that the patient has a clear and patent airway. Protect the patient from further spinal injury by preventing the head and torso from moving. Assess the patient for adequate breathing. Inspect and palpate the chest wall for decap BTLS. Open soft tissue injuries of the face and neck have a potential to interfere with the effectiveness of the airway and breathing. Evaluate the patient's voice and speaking ability. If an open injury is found on the chest, evaluate for air movement through the wound that indicate a deep penetrating injury. Assess the patient's back for injuries that might need treatment additionally. In regards to circulation, quickly assess the patient's pulse rate, rhythm, and quality. Determine skin condition, color, and temperature. Check capillary refill time. Your assessment of the pulse and skin will give you an indication as to how aggressively you need to treat the patient for shock. In terms of transport decision, make sure to consider whether transport to the closest hospital is appropriate or whether the patient would be better served by transport to a trauma center. The types of patients who need immediate transportation are patients who present with poor general impression, altered level of consciousness, dyspnea, abnormal vital signs, shock, and severe pain. Patients who have visible significant bleeding or signs of significant internal bleeding may quickly become unstable, so they are also in need of rapid transport to a trauma center. Let's discuss history taking. You want to always investigate the chief complaint. Obtain a medical history and be alert for injury-specific signs and symptoms and any pertinent negatives. Obtain a sample history from your patient. Using OPQRST may provide some background on isolated extremity injuries. When you use sample OPQRST and DCAP-BTLS together, your assessment will provide significant insight into the patient's overall condition. Any information you receive will be very valuable if the patient loses consciousness. If the patient is unresponsive, attempt to obtain history from other sources, such as friends or family members, bystanders, and medical identification jewelry. Cards in wallets also are a good source of information. Some typical signs of an open injury are bleeding, breaks in the skin, shock, hemorrhage, disfigurement of a loss of a body part, and chronic medical conditions such as anemia and hemophilia, as well as a host of other medical conditions that can complicate open soft tissue injuries. Now let's discuss secondary assessment. After you evaluate ABCs and identify and treat immediate life threats, a more detailed assessment should follow. The secondary assessment is a more systematic full-body scan or focused examination of the patient. The secondary assessment, which includes assessing interventions and repeating vital signs, typically occurs en route to the ED. With physical examination, you want to make sure you listen to breath sounds with a stethoscope, determine the patient's respiratory rate, note the pattern and quality of the respiratory effort, assess for asymmetric chest wall movement. Also, you want to assess the neurologic system. You want to check for level of consciousness, pupil size and reactivity, motor response, and sensory response. Assess the musculoskeletal system by performing a detailed exam of the entire body. Look for DCAP-BTLS. Assess the chest, abdomen, and extremities for hidden bleeding and injuries. Log roll the patient and assess the posterior torso for injuries. Once the back has been assessed, perform a complete spinal immobilization if indicated. Assess all anatomic regions. Check for jugular vein distension and tracheal deviation. Check for pelvis stability. Check the abdomen. Check the extremities and record pulse, motor, and sensory function. With vital signs, you want to reassess vital signs to identify how quickly the patient's condition is changing. Signs that indicate hypoperfusion and indicate the need for rapid transport include tachycardia, tachypnea, and low blood pressure. You also want to notice weak pulse and cool, moist, and pale skin. Reassessment of the patient's vital signs will indicate how well the patient is tolerating the injury and the effectiveness of your interventions. With reassessment should be conducted regularly during transport. Repeat the primary assessment and pay extra attention to areas of concern identified in the initial assessment. Assess the effectiveness of prior treatments and reassess vital signs and the chief complaint. Recheck patient interventions. Reassess the effectiveness of bandaging. Now let's discuss interventions. You want to assess and manage all threats to the patient's airway, breathing, and circulation. Give supplemental oxygen via a non-rebreathing mask to all patients with traumatic injuries that are impacting the airway or ventilation, or those with potential for shock. Expose all wounds, control bleeding, and be prepared to treat the patient for shock. Consider flushing small wound surfaces without significant bleeding with sterile saline prior to applying a dressing. If any material is quote-unquote stuck in the wound, do not remove it, as this may worsen bleeding and shock. Splint extremities that are painful, swollen, or deformed. Communication and documentation, as we've discussed before, are absolutely essential. Your communication and documentation must include a description of the MOI and the position in which you found the patient when you arrived on scene. Attempt to report blood loss using terms that you are comfortable with and that will be easily understood by other personnel. Include the location and description of any soft tissue injuries or other wounds you have located and treated. Describe the size and depth of the injury. Provide an accurate account of how you treated these injuries. Now, emergency medical care for closed injuries includes the following. You may have small contusions that generally required no special emergency medical care, but you should note their presence to determine the extent of the patient's overall injuries. For instance, if they have a large pattern of small bruises, for instance. More extensive closed injuries may involve significant swelling and bleeding beneath the skin, which could lead to hypovolemic shock. The injuries might not have had time to cause swelling or bruising, so closely watch any area of injury throughout the time you are caring for the patient, no matter how minor it may look upon initial assessment. Treat a closed soft tissue injury using the Rice's mnemonic for 1. Rest, R is rest, I is ice, C is compression, E is elevation, and S is splinting. That's the Rice's mnemonic, and I'm going to review it one more time. Rice's, R is for rest, I is for ice, C is compression, E is for elevation, and S is for splinting. Be alert for signs of developing shock, such as anxiety or agitation, changes in mental status, increased heart rate, increased respiratory rate, diaphoresis, cool or clammy skin, decreased blood pressure. If the patient exhibits signs and symptoms of shock, treat accordingly and aggressively. Before you begin to care for a patient with an open wound, follow standard precautions. If life-threatening bleeding is observed, assign a team member to apply direct pressure over the wound to control the bleeding. If the wound is in the chest, upper abdomen, or upper back, cover it with an occlusive dressing. Control bleeding using direct, even pressure and elevation, pressure dressings and/or splints, and tourniquets, and make sure you know the process and policy regarding tourniquets in your area. All open wounds are assumed to be contaminated and present a risk of infection. Applying a sterile dressing reduces the risk of further contamination. Do not remove material from an open wound, no matter how dirty the wound is. Small wound surfaces without significant bleeding can be flushed with sterile saline prior to applying a dressing. In most circumstances, hospital personnel, rather than EMTs, will clean open wounds. In some cases, you can better control bleeding from open soft tissue wounds by splinting the extremity even if there is no fracture. Now let's discuss abdominal wounds. An open wound in the abdominal cavity may expose internal organs. In an evisceration, the organs protrude through the wound. Cover the wound with sterile gauze moistened with sterile saline solution. Secure the gauze with an occlusive dressing and keep the organs moist and warm. Most patients with abdominal wounds require immediate transport to a trauma center. With impaled objects, you will occasionally have a patient with an impaled object such as a knife, fish hook, wood splinter, or piece of glass impaled in his or her body. To treat this injury, follow the steps in Skill Drill 26-1 in your text. Remove the impaled object only in two circumstances. A, the object is in the cheek or mouth and obstructs the airway. Or B, the object is in the chest and directly interferes with CPR or the need for potential CPR. If the object is very long, secure, then shorten it. Let me repeat that one more time. If the object is very long, secure and shorten it. Provide rapid transport. With neck injuries, you need to be extremely careful. Neck injuries, especially open neck injuries, can be life-threatening. If the veins of the neck are open to the environment, they may suck in air. If enough air is sucked into a blood vessel, it can block the flow of blood into the lungs and cause cardiac arrest. This condition is called an air embolism. Cover the wound with an occlusive dressing. Apply manual pressure, but do not compress both carotid arteries at the same time for obvious reasons. You would cut off all oxygen supply to the brain. This could impair major circulation to the brain and cause a stroke. Use caution with patients suffering from a neck injury depending on the MOI involved. Immobilize the C-spine if indicated, including placing a cervical collar. Now with bites, let's talk about small animal bites and rabies. Small animal bites and rabies are common, but consider the scene and crew safety prior to entering the environment. A small animal's mouth is heavily contaminated with virulent bacteria. Consider all small animal bites to be contaminated and potentially infected wounds, and treatment may require debridement or removal of damaged tissue, antibiotics, and tetanus prophylaxis, which is the tetanus shot, surgical repair. All small animal bites should be evaluated by a physician. A major concern is the spread of rabies, which is an acute, potentially fatal viral infection of the central nervous system that can affect all warm-blooded animals. The virus is in the saliva of a rabid or infected animal and is transmitted through biting or licking an open wound. An infection can be prevented only by a series of special vaccine injections. Children, particularly young children, may be seriously injured or even killed by dogs. The animal may turn and attack you as well. Do not enter the scene until the animal has been secured by the police or an animal control officer. With human bites, these are perhaps the most dangerous of all. The human mouth, more so than even the small animal's mouth, contains an exceptionally wide range of bacteria and viruses. Regard any human bite that has penetrated the skin as a very serious injury. Any laceration caused by a human tooth can result in a serious spreading infection. In fact, people have been known to lose hands from getting into fist fights where their opponent's teeth broke the skin of the fist. So human bites are extremely contaminated and extremely serious. Now let's talk about emergency treatment for hand infections. Emergency treatment consists of the following step. Apply a dry, sterile dressing. Promptly immobilize the area with a splint or bandage. Provide transport to the ED for surgical cleansing of the wound and antibiotic therapy. The next thing we're going to discuss is burns. Burns account for approximately 3,400 deaths per year. Burns are among the most serious and painful of all injuries. A burn occurs when the body or a body part receives more radiant energy than it can absorb, resulting in an injury. Potential sources of this energy are heat, toxic chemicals, and electricity. Although a burn may be the patient's most obvious injury, you should also always perform a complete assessment to determine whether other serious injuries are present. Children, older patients, and patients with chronic illnesses are more likely to experience shock from burn injuries. Let's discuss the pathophysiology of burns. Burns are soft tissue injuries that are spread out over large areas and are created by the transfer of radiation, thermal, or electrical energy. Thermal burns can occur when the skin is exposed to temperatures higher than 111 degrees Fahrenheit or 44 degrees Celsius. The severity of a thermal injury correlates directly with temperature, concentration, and the amount of energy possessed by the object or substance, and the duration of exposure. Burn injuries are progressive. The greater the heat energy, the deeper the wound. People naturally limit the amount of time they're exposed to such heat. If clothing is on fire or if the person is trapped or unconscious, exposure time can be vastly extended. Complications of burns can include the following. The skin serves as a barrier between the environment and the body. When a person is burned, this barrier is destroyed. If burns create a high risk for infection, hypothermia, hypovolemia, and shock. Burns to the airway are of significant importance because the loose mucosa in the hypopharynx can swell and lead to complete airway obstruction. Circumferential burns of the chest can compromise breathing, and circumferential burns of an extremity can lead to compartment syndrome, resulting in neurovascular compromise and irreversible damage if not appropriately treated. If you suspect complications, call for ALS backup immediately. Now let's discuss burn severity. There are 5 factors to help determine the severity of a burn. The first 2 factors are the most important. First, what is the depth of the burn? And B, what is the extent of the burn? C, are there any critical areas involved? The face, upper airway, hands, feet, and genitalia. Does the patient have any pre-existing medical conditions or other injuries? And is the patient younger than 5 years or older than 55 years of age? Burns to the face are of particular importance owing to the potential of airway involvement. Burns to the hands or feet or over joints are considered serious because of the potential for loss of function as a result of scarring. Now let's discuss depth of burns. You have superficial or first-degree burns, which means that this only involves the top layer of the skin or the epidermis. It's like a sunburn. 2 is the skin turns red, but it does not blister or burn through this top layer. So that is a first-degree burn. The burn site is often painful because the nerve endings are exposed. And again, the perfect example is a sunburn. The second type of burn is a partial thickness or second-degree burn. It involves the epidermis and some portion of the dermis itself. So again, a partial thickness or second-degree burn involves not only the epidermis, but has burned into some portion of the dermis as well. These burns do not destroy the entire thickness of the skin, nor is the subcutaneous tissue impaired. Typically, the skin is moist, mottled, and white to red, and most often blisters are present or can form shortly after exposure. These cause intense pain because of the exposure of nerve endings. Full thickness and third-degree burns are the third type of burn we're going to discuss, and these extend through all skin layers and may involve subcutaneous layers all the way down through the muscle, down to the bone, or even into the internal organs. The burned area is dry and leathery and may appear white, dark brown, or even charred in appearance. If the nerve endings have been destroyed, a severely burned area may have no feeling at all. The surrounding, less severely burned areas, however, may be extremely painful. Significant airway burns are serious, and they may be associated with singed hair within the nostrils, soot around the nose and mouth, hoarseness, and hypoxia. These patients should be rapidly transported to an ED or a facility capable of an advanced airway management system. Here is an example of burn severity. You see on the left, which is a superficial burn, which is like a sunburn. The middle picture is a partial thickness or second degree burn, and you see blistering present and some damage into the dermis itself. And then on the far right, you see a full thickness or third degree burn, which goes all the way into the subcutaneous layers, and again may go all the way down even to the bone or internal organs. Now let's discuss the extent of burns. A rule of thumb is that it estimates the surface area that has been burned by comparing it to the size of the patient's palm, which is roughly equal to 1% of the patient's total body surface area. A rule of nines estimates the extent of a burn by dividing the body into sections, each representing approximately 9% of the total body surface area. The proportions differ for infants, children, and adults. When you calculate the extent of burn injury, include only partial and full thickness burns. Document superficial burns, but do not include them in the body surface area estimation of extent of burn injury. The illustration on this slide shows how to apply the rule of nines to an infant, child, and adult. And you can see how great the differences are between the three stages of development. Now let's discuss patient assessment of burns. When assessing a burn, it is important to classify the patient's burns. One classification of burns is based on the source of the burn, depth of the burn, severity of the burn. As always, you do proper scene size up and evaluate for scene safety. Observe the scene for hazards and threats to the safety of you and your crew, bystanders, and to the patient themselves. Ensure that the factors that led to the patient's burn injury do not pose a hazard to you and your crew. Also consider the mechanism of injury. An attempt to determine the type of burn that has been sustained and the MOI. What the patient reports will often provide important information about the extent of the injury. Assess the scene for any environmental hazards. Determine the number of patients. Call for additional resources early if necessary. Consider the potential for spinal injuries, broken bones, inhalation injuries, and other types of injuries as well. What the patient reports will often provide important information about the extent of the injury or injuries. Assess the scene for any environmental hazards. Determine the number of patients, and call for additional resources early if necessary. Consider the potential for spinal injuries, broken bones, inhalation injuries, and other injuries. Now let's talk about primary assessment. Begin with a rapid exam. Form a general impression and look for clues to determine the severity of injuries and the need for rapid treatment. Be suspicious of clues that may indicate abuse. Consider the need for manual spinal stabilization and check for responsiveness using the AVPU scale. In all patients whose level of consciousness is less than alert and oriented, administer high-flow oxygen via a non-rebreathing mask and provide immediate transport. In regards to airway and breathing, make sure to ensure that the patient has a clear and patent airway. Be alert to signs that the patient has inhaled hot gases or vapors, and indicators can be singed facial hair and soot present in or around the airway, such as the mouth and nostrils. Heavy amounts of secretions and frequent coughing may also indicate a respiratory burn. Quickly assess for adequate breathing. Inspect and palpate the chest wall for DCAT BTLS. With circulation, you want to quickly assess the pulse rate and the quality. Determine perfusion based on the patient's skin condition, color, temperature, and capillary refill time. Take steps to control significant bleeding. If the patient has obvious life-threatening external hemorrhage, control the bleeding first before airway and breathing, then treat the patient for shock as quickly as possible. Treat shock and burn patients by preventing heat loss and cover the patient with a blanket. As far as transportation decision, consider rapid transport for a patient who has an airway or breathing problem, significant burn injuries, significant external bleeding, signs and symptoms of internal bleeding, and then also consulting with ALS providers may be appropriate. With history taking, investigate the chief complaint. Be alert for signs or symptoms of other injuries due to the MOI. If the patient was burned in a confined space, suspect an inhalation injury. When burns result from explosive forces, be alert for other internal injuries and fractures. Obtain a medical history and be alert for injury-specific signs and symptoms and permanent negatives. Typical signs of a burn are pain, redness, swelling, blisters, and charring. Symptoms may include pain or burning at the injury site. Regardless of the types of burn injury, you want to stop the burning process, apply a dressing to prevent contamination, and treat the patient for shock. A sample history is key. Along with the sample history, ask the following questions. Are you having any difficulty breathing? Are you having any difficulty swallowing? Are you in any pain? And check whether the patient has an emergency medical identification device of some type. With your secondary assessment, you want to take your physical examination and perform an exam of the entire body and assess the patient from head to toe looking for DCAT BTLS. Make a rough estimate using the rule of nines of the extent of the burned area. Determine the classification of the burns so that the victim has sustained. Determine the classification of the burns that the victim has sustained and determine the severity of the burns. Package the patient for transport based on your findings. Assessment of the upper respiratory system involves looking, listening, and feeling. Look for soot around the mouth and soot around the nose or singed nasal hair. If any of those findings are present, open the patient's mouth and examine for burns or swelling of the tongue. Ask the patient to cough and assess for black sputum, which indicates smoke inhalation. Listen to the breath sounds with a stethoscope. Assess pulse rate and quality, determine the skin condition, color, and temperature, and check the capillary refill time. Assess the patient's neurological system, the level of consciousness using AVPU, pupil size and reactivity, motor response, and sensory response. Assess the musculoskeletal system. In the head, check for singed nasal or facial hair, burns or swelling of the face or ears, or burns or swelling in the mouth. In case of electrical injury, examine the scalp for entrance or exit wounds. In the neck, check for burns, especially if they encircle the entire neck, which can impair circulation. In the chest, check for burns that encircle the entire chest, which can impair normal chest rise. In the abdomen and pelvis, feel all four quadrants for tenderness or rigidity. If the abdomen is tender, expect internal bleeding. Look for signs of burns in the genitalia, as burns to this area are considered high risk. Look for burns that encircle an extremity, as they can impair circulation. If the patient sustained an electrical injury, assess thoroughly for entry or exit burn wounds. Record pulse and motor sensory function. Examine the posterior surface of the body, as large burns or electrical exit burns may be located in this body area. Some vital signs to pay attention to are determining an early set of vital signs will help you to know how a patient is tolerating his or her injuries because you've established a baseline. Blood pressure, pulse, and skin assessment for perfusion are important signs to obtain. So use monitoring devices such as oxygen saturation monitor and carbon monoxide monitors. With reassessment, you want to repeat the primary assessment and reassess the patient's vital signs. Reassess the patient's chief complaint and reevaluate interventions and treatments you have provided to the patient. Stop the burning process, assess and treat breathing, and support circulation. Provide rapid transport, and oxygen is mandatory for inhalation burns and large body surface area burns. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. With communication and documentation, you want to provide hospital personnel with a description of how the burn occurred. Describe the extent of the burns, the amount of body surface area involved, depth of the burn, location of the burn, and if special areas are involved, they should be specifically mentioned and documented. With emergency medical care for burns, your first responsibility in caring for a patient with a burn is to stop the burning process and prevent additional injury. When caring for a burn patient, follow the steps in Skill Drill 26-2 in your text, which you will practice in class. Now let's discuss thermal burns. Thermal burns are caused by heat. Most commonly, they are caused by scalds or an open flame. A flame burn is very often a deep burn, especially if a person's clothing catches fire. A scald burn is the most commonly seen in children and handicapped adults, but it can happen to anyone, particularly while cooking. Hot liquids produce scald injuries. Scald burns often cover large surface areas of the body because the liquids can spread quickly. Coming in contact with hot objects produces a contact burn. Contact burns are rarely deep unless the patient was prevented from drawing away from the hot object. A steam burn can produce a topical or a scald burn. Minor steam burns are common when microwaving foods covered with plastic wrap. A flash burn is produced by an explosion which may briefly expose a person to very intense heat. Lightning strikes can cause a flash burn, for example. With management of thermal burns, you want to stop the burning source, cool the burned area if appropriate, and remove all jewelry. Maintain a high index of suspicion for inhalation injuries. Increased exposure time will increase damage to the patient, So the larger the burn, the more likely the patient will be susceptible to hypothermia and or hypovolemia. All patients with large surface burns should have a dry, sterile dressing applied to help maintain body temperature, prevent infection, provide comfort. With inhalation burns, inhalation injuries occur when burning takes place in an enclosed space without ventilation. When the upper airway is exposed to excessive heat, the patient can experience rapid and serious airway compromise. Upper airway damage is often associated with the inhalation of superheated gases. Lower airway damage is often associated with the inhalation of chemicals and particulate matter. When treating a patient for inhalation injuries, you may encounter severe upper airway swelling which requires immediate intervention. Consider requesting ALS backup if the patient has signs and symptoms of edema, such as stridor, hoarse voice, singed nasal hairs, burns of the face, and carbon particles in their sputum. Apply cool mist, aerosol therapy, or humidified oxygen to help reduce some minor edema. Apply an ice pack to the throat to reduce swelling and providing the tissue that area does not have burns. In other words, let me say that one more time. Apply an ice pack to the throat to reduce swelling, provided that the tissue in that area does not have burns present. The combustion process produces a variety of toxic gases. The less efficient the combustion process, the more toxic the gases may be created. Carbon monoxide or CO intoxication should be considered whenever a group of people in the same place all report a headache or nausea. Cherry red skin, lips, and nail beds are commonly observed in patients who have died from CO exposure. Do not rule out CO exposure simply because a patient's skin is not cherry red. Hydrogen cyanide, or HCN, is generated by combustion, and signs and symptoms involve the central nervous system, respiratory systems, and cardiovascular systems, and cause faintness, anxiety, and abnormal vital signs, headache, seizures, paralysis, and coma. With management of inhalation burns, you must ensure your own safety and the safety of your coworkers first, always. Pre-hospital treatment of a patient with a suspected hydrogen cyanide poisoning includes decontamination and supportive care until an antidote can be administered by ALS providers. So if that's suspected or known, you must contact ALS immediately. Care for any toxic gas exposure by recognition, identification, and supportive treatment. With chemical burns can occur whenever a toxic substance contacts the body. Most chemical burns are caused by strong acids or strong alcohols. The eyes are particularly vulnerable. The severity of the burn is directly related to three factors: the type of chemical, the concentration of the chemical, and the duration of the exposure. To prevent exposure to hazardous materials, determine if you can safely approach the patient. In some cases, you must wait until a hazardous material or a hazmat team has decontaminated the patient. Wear appropriate chemical-resistant gloves and eye protection whenever you are caring for a patient with chemical burn. Treatment for chemical burns can be specific to the chemical agent itself. Management of chemical burns involves the following. The severity of the burn will depend on the type of chemical, its strength, duration and exposure, and the areas of the body exposed. To stop the burning process, remove any chemical from the patient. Always brush dry chemicals off the skin and clothing before flushing the patient with water, because some dry chemicals and water do not get along. Remove the patient's clothing, including shoes, stockings, gloves, and any jewelry or eyeglasses. Take great care to ensure you do not come in contact with the chemical. The patient should be properly decontaminated by properly trained personnel. For liquid chemicals, immediately begin to flush the burned area with large amounts of water. Continue flooding the area with gallons of water for 15 to 20 minutes after the patient says the burning pain has stopped. If the patient's eye or eyes have been burned, hold the eyelid open without applying pressure over the globe of the eye itself while flooding the eye with a gentle stream of water. As with any substance, once the fluid has been contaminated with the chemical, collect it and properly dispose of it. Conduct a proper decontamination prior to loading any patient into the ambulance and again prior to entering a hospital. With electrical burns, they may be the result of contact with high or low voltage electricity. High voltage burns may occur when utility workers make direct contact with power lines. Ordinary household current can cause severe burns and cardiac arrhythmias. For electricity to flow, there must be a complete circuit between the electrical source and the ground. And an insulator is any substance that prevents this circuit from being completed. A conductor is any substance that allows a current to flow through it. The human body is a good conductor. Electrical burns occur when the body, or a part of it, completes a circuit connecting a power source to the ground. The type of electrical current, magnitude of current, and voltage have effects on the seriousness of burns. Your safety is of particular importance when you are called to the scene of an emergency involving electricity. You can be fatally injured by coming into contact with power lines. You can also be fatally injured by touching a patient who is still in contact with a live power line or any other electrical source. If they're grounded and you touch them, then you become grounded as well. Never attempt to remove someone from an electrical source unless you are specially trained to do so, which you will not be able to be trained to do. Always assume that any down power line is live when you're at a scene as well. A burn injury appears when the electricity enters and exits the body. There are two dangers specifically associated with electrical burns, and there may be a large amount of deep tissue injury. The patient may go into cardiac or respiratory arrest from the electrical shock. If the patient is not in cardiac arrest on your arrival, he or she is unlikely to experience this problem during transport. Here's an example of an electrical burn. They're pretty horrific, but this is what they look like. Now let's discuss management of electrical burns. Electrical current can cross the chest and cause a cardiac arrest or arrhythmias. If indicated, begin CPR on the patient and apply the automated external defibrillator or AED. Be prepared to defibrillate if necessary. Give supplemental oxygen and monitor the patient closely for respiratory and cardiac arrest. Treat the soft tissue injuries by applying dry, sterile dressings on all burn wounds and splinting suspected fractures. Provide prompt transport. Now let's discuss taser injuries. In recent years, law enforcement has increased its use of tasers. These weapons fire two small darts or electrodes that puncture the patient's skin. The barbs are generally treated as impaled objects and removed by a physician. In some jurisdictions, depending on local protocols, EMTs are permitted to remove these barbs from patients. There are potential complications for the patient when these devices have been used, particularly when the patient is experiencing certain underlying disorders. They can have excited delirium, which is commonly associated with illegal drug ingestion. They can have excited delirium, which is a true emergency and warrants assisted ALS response. Using a taser device in patients with true excited delirium has been previously associated with dysrhythmias and sudden cardiac arrest, and it can also cause cardiac arrest in patients with undiagnosed or unknown heart conditions. Make sure you have access to an AED when you respond to patients who have been exposed to a taser shot. Now let's discuss radiation burns. Acute radiation exposure has become more than a theoretical issue because of the use of radioactive materials that has increased in industry and medicine. Potential threats include incidents related to the use and transportation of radioactive isotopes and intentionally released radioactivity in terrorist attacks. You must determine if there has been a radiation exposure and then attempt to determine whether ongoing exposure continues to exist. There are three types of ionizing radiation. Alpha, which is alpha particles that have little penetrating energy. They're easily stopped by the skin. Then you have beta particles. Beta particles have greater penetrating power and can travel much farther in air than alpha particles. They can penetrate the skin, but can be blocked by simple protective clothing designed for this purpose, such as a lead suit, for example. Gamma rays are the most destructive. The threat from gamma radiation is directly proportional to its wavelength, and this type of radiation is very penetrating and easily passes through the body and solid materials and completely disrupts DNA. And the longer you're exposed to it, the more complete that disruption is. Most ionizing radiation accidents involve gamma radiation or X-rays. People who have sustained a radiation exposure generally do not pose a risk to others, but in incidents involving explosions, patients may be contaminated. So with management of radiation burns, you want to maintain a safe distance and wait for the hazmat team to decontaminate the patient before initiating care. Most contaminants can be removed by simply removing the patient's clothes. Call for additional resources, absolutely. Once there is no threat to you, begin treating the ABCs and treat the patient for any burns or trauma. Irrigate any open wounds. Notify the emergency department specifically that you've got a potentially radioactive patient coming in. They have to take special precautions. Identify the radioactive source and the length of the patient's exposure to it. Limit your duration of exposure. Increase your distance from the source and attempt to place shielding between yourself and sources of gamma radiation. Now let's discuss dressing and bandaging. All wounds require bandaging. Splints can help control bleeding and provide firm support for dressing. Many different types of dressings and bandages exist. Dressings and bandages have three functions. 1, to control bleeding. 2, to protect the wound from further damage. And 3, to prevent further contamination and infection of the wound. Now let's discuss sterile dressings. Most wounds will be covered by universal dressings, and they're conventionally 4 by 4 inches or 4 by 8 inches in width, and they're gauze pads. There are assorted small adhesive type dressings that are also available, and soft self-adherent roller dressings, and you'll commonly heard that referred to as Kerlix. The universal dressing is ideal for covering large open wounds. Gauze pads are appropriate for smaller wounds. Adhesive type dressings are useful for minor wounds, and those are like Band-Aids. Occlusive dressings prevent air and liquids from entering or exiting through the wound. And occlusive dressings are made of a Vaseline-infused gauze, aluminum foil, or plastic, and used to cover sucking chest wounds, abdominal eviscerations, penetrating back wounds, and neck injuries. When we talked about the different types of dressings, now we're going to talk about bandages. And bandages are designed to keep the dressings in place during transport, and you can use soft roller bandages, rolls of gauze, triangular bandages, adhesive tape. And the self-adherent soft roller bandages are easiest to use, and those are again known as Kerlix. And Kerlix can come with a cotton inner lining, but most typically it's found as a bandage and it's self-adherent. Adhesive tape holds many small dressings in place and helps to secure larger dressings. Some people are allergic to adhesive tape. With these individuals, use paper or plastic tape. Do not use elastic bandages to secure dressings. If the injury swells, the bandage may become a tourniquet and then cause further damage. So always check a limb distal to a bandage for signs of impaired circulation and loss of sensation. And it's important to check that circulation prior to bandaging and then after bandaging and then periodically after bandaging. Now, air splints and vacuum splints are useful in stabilizing broken extremities and can be used with dressings to help control bleeding from soft tissue injuries. If a wound continues to bleed despite the use of direct pressure, quickly proceed to the use of a tourniquet, again following local protocols. Okay, class, now let's review everything we covered in this chapter. So, for review, question number 1. A young male was struck in the forearm with a baseball and complains of pain to the area. Slight swelling and ecchymosis are present, but no external bleeding. Which type of injury does this describe? A. Abrasion, B. Contusion, C. Hematoma, or D. Avulsion? Of course, the answer is B, a contusion or a bruise, and it's caused by direct blunt force trauma. Most of us having experienced quite a few of these in our lifetime, this answer should have been quite obvious. And in a bruise, the epidermis remains intact, but small blood vessels in the dermis are injured. The depth of the injury varies depending on the amount of energy absorbed. Pain and swelling occur as fluid and blood leak into the damaged area. The buildup of blood produces a characteristic blue and black discoloration called ecchymosis. Okay, let's look at the incorrect answer. A young male was struck in the forearm with a baseball and complains of pain to the area. Slight swelling and ecchymosis are present, but no external bleeding. Which type of injury does this describe? A. Abrasion. Well, that's incorrect, because an abrasion, by definition, is a wound of the superficial layer of the skin caused by friction of some sort. Of course, B. Contusion or bruise is the correct answer. C. Hematoma, by definition, is blood that has collected within damaged tissue or in a body cavity, and hematomas are usually associated with large blood vessel damage and pretty predominant, if not very heavy, blood loss. And an avulsion, by definition, is an injury that separates various layers of tissue. So again, contusion is the correct answer. Number 2, a compression injury that is severe enough to cut off blood flow below the injury is called an A. Contusion, B. A hematoma, C. A local thrombus, or D. Compartment syndrome. So let's take a look at the correct answer. It is D. Compartment syndrome can occur when a part of the body has been compressed for a prolonged period of time, usually greater than 4 hours. The injured tissue begins to swell, which can impede arterial blood flow and venous return. As a result, the part of the body distal to the compression site becomes hypoxic, and metabolic waste products, such as lactic acid, begin to accumulate. Let's look at the incorrect answers. To remind you of the scenario, a compression injury that is severe enough to cut off blood flow below the injury is called A, a contusion. That's incorrect because, again, a contusion is a bruise. B, a hematoma. That's incorrect because, by definition, a hematoma is blood that has collected within damaged tissue, and a hematoma occurs when a large blood vessel is injured. C, a local thrombus. That's just a blood clot. So D is compartment syndrome. That is the correct answer. And just to remind you, a compartment syndrome injury is a compression injury that is severe enough to cut off blood flow below the injury or below the site of injury. And that, again, is called compartment syndrome. Review question 3. A 45-year-old convenience store clerk was shot in the right anterior chest during a robbery. Your assessment reveals that the wound has blood bubbling from it every time the patient breathes. Your most immediate action should be to A, prevent air from entering the wound. B, cover the wound with a bulky dressing. C, assess the patient's back for an exit wound. Or D, transport the patient promptly to the closest trauma center. If you think about this carefully, you'll definitely get this one right. It is, of course, A. Immediate treatment for this injury. This injury is a sucking chest wound. So immediate treatment for a sucking chest wound or an open pneumothorax involves covering the wound with an occlusive dressing. This will prevent air from being drawn into the chest cavity. After covering the wound, assess for an exit wound and apply high flow oxygen if not already done, and transport promptly. Again, also consider your time factors and if there is immediate and available ALS to assist. But time is of the essence, so your best bet is to cover with occlusive dressing, check for an exit wound, high flow oxygen, and get them to the hospital immediately. Let's look at the incorrect answers. Again, a 45-year-old convenience store clerk was shot in the right anterior chest during a robbery. Your assessment reveals that the wound has bubbling from it every time the patient breathes. Your most immediate action should be to A, prevent air from entering the wound. Of course, that's correct. B, cover the wound with a bulky dressing. That's not going to do any good because you must use an occlusive dressing. If you use a bulky dressing, it's still porous, so there's still air entering that sucking chest wound. C, assess the patient's back for an exit wound. You do this after the anterior chest wound is covered. Okay, so cover the sucking chest wound, then check for an exit wound of some kind. In this case, you're checking for an exit wound because they've been shot. D, transport the patient promptly to the closest trauma center. Do this after the initial treatment of an open chest wound. If you don't do that first, their chances of making it to the hospital alive are pretty slim. So cover that sucking chest wound, check for an exit wound, high flow oxygen, get them to a trauma center right away, and in that order. Okay, review question 4. What effects will the application of ice have on a hematoma? A, vasodilation and increased pain. B, vasodilation and decreased bleeding. C, vasoconstriction and increased swelling. Or D, vasoconstriction and decreased bleeding. Okay, think about what is happening in the layers of skin during a hematoma, and then think about your definitions, and I'm sure you'll come up with the correct answer. And the correct answer is D. Applying an ice pack to a closed wound, such as a hematoma, will decrease bleeding, pain, and swelling by causing constriction of the blood vessels. Let's look at the incorrect answers. What effect will the application of ice have on a hematoma? A, vasodilation and increased pain. Well, an ice pack causes vasoconstriction and will therefore reduce pain. B, vasodilation and decreased bleeding. An ice pack causes vasoconstriction but will also reduce bleeding because it's constricting the blood vessels. C, vasoconstriction and increased swelling. Those are contraindicatory because vasoconstriction is going to only reduce swelling, not increase it. So of course, D, vasoconstriction and decreased bleeding and of course swelling is the correct answer. Review question 5. The primary reason for applying a sterile dressing to an open injury is to A, prevent contamination, B, control external bleeding, C, reduce the risk of infection, or D, minimize any internal bleeding. Of course, it is B. Although prevention of contamination is an important reason for applying a sterile dressing to an open injury, the primary reason is to control the external bleeding associated with it. So the idea is not only to just stop the bleeding, but also do it with the cleanest dressing possible. But your main objective here is to control bleeding. Let's look at the incorrect answers. The primary reason for applying a sterile dressing to an open injury is to A, prevent contamination. This is important, but not the primary reason. Right now, you're trying to control bleeding. B, control external bleeding, which is of course the correct answer. C, reduce the risk of infection. The prevention of contamination will also reduce the risk of infection, which is why you use a sterile dressing. But again, your main objective is first and foremost controlling bleeding. D, minimize any internal bleeding. Well, internal bleeding is minimized by the application of pressure bandage to an open wound. So your main objective is, again, in this case, to use a sterile dressing, but mainly to control bleeding. Question 6. The most appropriate way to dress and bandage an open abdominal wound with a loop of bowel that is protruding from this open wound is to A, cover the wound with a dry sterile dressing and apply firm pressure. B, apply a moist sterile dressing to the wound and apply firm pressure. C, apply a moist sterile dressing to the wound and secure with an occlusive dressing. Or D, carefully replace the protruding bowel into the abdomen and cover the wound. If you read these carefully, then with logic, you should definitely get the correct answer. And that correct answer is C. Treatment for an abdominal evisceration includes applying a moist sterile dressing to the wound because you do not want the loop of bowel to dry out, and then covering the moist dressing with an occlusive dressing to prevent any moisture from evaporating. It keeps the moisture there in the area of injury. Do not replace a protruding bowel back into the wound or apply firm pressure, which may force the bowel back into the wound, and these actions increase the risk of infection. You never want to disturb any bowel that's protruding. You can injure the bowel, you can cause injury to the blood supply of the bowel, causing necrosis, and it takes surgeons many years and lots of practice to be able to repack bowel into a wound where it's been eviscerated or where they've had to move bowel during surgery. So you want to keep it moist, put an occlusive dressing over it, and let the surgeons do the rest. Let's look at the incorrect answers. The most appropriate way to dress and bandage an open abdominal wound with a loop of bowel protruding is to A, cover the wound with a dry sterile dressing and apply firm pressure. Incorrect. You must use a moist dressing, and you're not going to apply pressure. just because a bowel is eviscerated doesn't mean you're going to have a lot of blood supply. So you don't need to be bearing down on the wound. And in fact, you can cause an impaction of the bowel on top of everything else. B, apply a moist, sterile dressing to the wound and apply firm pressure. Again, you should not apply pressure. C, apply a moist, sterile dressing to the wound and secure with an occlusive dressing. That is the correct answer. Keep it moist and put the occlusive dressing on there to trap that moisture in there. Don't apply any pressure and transport them immediately. D is incorrect. D says carefully replace the protruding bowel into the abdomen and cover the wound. Again, as I mentioned, never force a bowel back into the abdominal cavity. It takes years of practice to manage to do this correctly, and it, while may be tempting, can cause extremely serious, if not outright fatal, repercussions for the patient. Review question 7. A 22-year-old male was attacked by a rival gang and has a large knife impaled in the center of his chest. Your assessment reveals he is apneic and pulseless. You should A, carefully remove the knife, control any bleeding, begin CPR, and transport. B, stabilize the knife in place, provide rescue breathing, and transport at once. C, remove the knife and control any bleeding, apply the AED, and analyze his rhythm. Or D, begin CPR, control any external bleeding, and transport rapidly to a trauma center. Read these carefully. Use your logic, plus the knowledge you've built up till now, and I know you'll get the correct answer. It is A. As a rule, impaled objects should be stabilized in place. However, if they interfere with the patient's breathing or your ability to perform CPR, they should be removed. However, you cannot perform CPR on a patient if a knife is impaled in the center of the chest. So, carefully remove the knife, control any bleeding, begin CPR, and transport at once. The AED is not indicated for patients with traumatic cardiac arrest. Their arrest is usually caused by massive blood loss, not a primary cardiac dysrhythmia, which is what's associated with a typical heart attack. So let's look at the incorrect answers. Just to remind you of the scenario, a 22-year-old male was attacked by a rival gang and has a large knife impaled in the center of his chest. Your assessment reveals he is apneic and pulseless. You should A, carefully remove the knife, control any bleeding, begin CPR, and transport. That is the correct answer. B, stabilize the knife in place, provide rescue breathing, and transport at once. Well, this is incorrect because the knife must be removed to provide effective CPR. He is pulseless. So you're looking at the lesser of two evils here. And in this case, the lesser of the two evils is to carefully remove the knife and begin CPR and hope for the best and hope that a major blood vessel has not been lacerated by the knife. But again, you're choosing the lesser of two evils. In this case, the fact that he needs CPR is going to override everything else. C, remove the knife and control any bleeding, apply the AED, and analyze his rhythm. That's completely incorrect because an AED is not recommended in traumatic cardiac arrest. In other words, because of some type of chest injury to the heart itself. But CPR must be initiated, okay? But you aren't going to apply the AED and analyze his rhythm because his heart has not stopped because of a heart attack or some type of fatal rhythm that has developed. His heart stopped because of point-blank trauma. D, begin CPR, control any external bleeding, and transport rapidly to a trauma center. Well, the impaled object must be removed prior to the initiation of chest compressions, and that should be for obvious reasons. Question 8. Which of the following is considered a severe burn? A, any full thickness burn. B, 20% partial thickness burn. C, 10% full thickness burn with abrasions. Or D, 5% full thickness burn with a fracture. Okay, think about severe burns and the most severe burns and the kinds of issues that it causes to the organism as a whole. All right, and then you should be able to get the correct answer. It is D. Severe burns include the following: full thickness burns involving the hands, feet, face, airway, or genitalia. Full thickness burns covering more than 10% of the body's total surface area, or BSA. Partial thickness burns covering more than 30% of the BSA. Burns involving the respiratory tract, such as smoke inhalation. Burns complicated by fractures, and burns on patients younger than 5 years old or older than 55 years old that would otherwise be classified as quote-unquote moderate burns on younger adults. So this is a little bit complex, so let's work through this piece by piece. Number 8, which of the following is considered a severe burn? A, any full thickness burn. Well, a full thickness burn is severe if it covers more than 10% of the body or involves the hands, feet, face, and genitalia. Okay, so if any of those factors are in place, then that full thickness burn would be considered severe. B, a 20% partial thickness burn. That would be considered a severe burn if it covers more than 30% of the body surface. C, a 10% full thickness burn with abrasions. This burn must be greater than 10% of the body's surface area. Okay, so any full thickness burn with abrasions that covers more than 10% of the body surface area is considered a severe burn. And D, a 5% full thickness burn with a fracture. That's the correct answer here for this particular scenario, because out of all of these scenarios, this is the most severe because you have a full thickness burn with a fracture. And the reason that is so particularly deadly is because the full thickness burn can go all the way down to the bone, as we know from reviewing earlier, but it's complicated with a fracture for two reasons. The burn has gone down to the surface of the bone, and the bone is covered with that vascular covering, also that vascular covering can become infected, which is called osteomyelitis. So you not only are running the risk of not only having a severe burn, but it's compounded with the fracture, which it can produce damage to the osteum, that bloody covering, bloody vascular covering of the bone, and also infection of that, which is called osteomyelitis. So out of all of these scenarios, this one is considered the most severe. So you have to think logically when dealing with burns, but think quickly. So this is one of those situations where you study and study and study, and it should be on automatic recall so you know exactly what you're dealing with and what the risks to the patients are. A 5-year-old boy was burned when he pulled a barbecue grill over on himself. This is every grown-up's nightmare. He has a partial and full thickness burns to his anterior chest and circumference circumferentially on both arms. What percentage of his body surface area has been burned? A, 18%, B, 27%, C, 36%, or D, 45%. Remember, with children and infants and adults, these ratios vary. So let's take a look at the correct answer. It is B. Using the pediatric rule of nines, the anterior chest accounts for 9% of the body surface area. The entire anterior trunk, which includes the chest and abdomen, accounts for 18% of the body surface area, and each arm accounts for 9% of the body surface area. Therefore, this child has experienced 27% body surface area burns. Looking at the incorrect answers, just to remind you of the scenario, a 5-year-old boy was burned when he pulled a barbecue grill over on himself. He has partial and full thickness burns to his anterior chest and circumferentially on both arms. What percentage of his body surface area has been burned? A, 18%. This is incorrect because 18% would indicate the patient's arms only. B, 27%, that's the correct answer, and you can go back to the previous slide if you like to review this, but we did just review it. However, I do suggest that you go back and review all of the percentages for determining the total BSA affected in burns. C, 36%. The patient's chest is 9% and both arms are 18%. So that's not correct in this particular scenario. And D, 45%. In this particular scenario, this is not correct also because the patient's chest is 9% and both arms are 18%. And as I just mentioned, please make sure you go back and review infant, pediatric, and adult rules of nines so that you're able to quickly and accurately assess the total body surface area affected in burns. Okay, class, number 10, this is our last review question. And it reads as following. Which of the following statements regarding chemical burns is false? So again, bear that in mind. Which of the following statements regarding chemical burns is false? A, most chemical burns are caused by strong acids or alkalis. B, fumes of strong chemicals can cause burns to the respiratory tract. C, prior to removing a dry chemical, you should flush the area with sterile water. Or D, you should not attempt to neutralize an acid burn with an alkaline chemical. Remember, which one of these is false? The answer is, of course, C. Dry chemicals should always be brushed off the patient before irrigating the wound with sterile water or saline. Failure to do so may increase the burning process and cause further tissue damage. Not all dry chemicals are water friendly, so the chemical itself may already be irritating and burning the patient, and if it happens to react negatively to water, then you can have a very serious potential problem on your hands. So let's look at the other answers. Number 10, which of the following statements regarding chemical burns is false? Most chemical burns are caused by strong acids or alkalis. That's true. Chemical burns are caused by acids and alkalis. B, Fumes of strong chemicals can cause burns to the respiratory tract. Again, that's also true. Chemicals are in the fumes and will cause respiratory tract burns. So if you think about, just like in movies, you'll see a vat of acid spilled, and the fumes that come off, immediately everybody starts coughing because the fumes affect the respiratory tract. So B is true. C, prior to removing a dry chemical, you should flush the area with sterile water. Of course, that's false. That's why it's the correct answer here. You must brush away as much of the dry chemical as possible before allowing any water to come in contact with that area. D, you should not attempt to neutralize an acid burn with an alkaline chemical. Well, that's true because literally it would take a chemist to perform this procedure. Too much alkaline would cause burning to the patient's skin. Okay, class, that is the end of this chapter. As always, I appreciate your time and attention. Please be sure to contact your instructor if you have any issues or questions or any type of confusion that needs to be cleared up so that you're absolutely clear on this and all subject matter. Please make sure you read your chapter carefully, do all of the exercises, review your skill sheets, and again, thank you for your time and attention, and we'll see you next class.